bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, and the McMaster Children's Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities.
Hello, everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Paediatric Health Centres. And today's webinar is titled The Value of Pediatric Surgical Wait Times Data, the Stollery Children's Hospital's Experience. So now let's get on to the presentation. Today we're going to hear from one of CAFC's programs that if you're part of this program, you're certainly familiar with it, but some of you may not be as familiar with this program of CAFC, which is the Canadian Paediatric Decision Support Network, or CAFC CPDSN, which is CAFC's national benchmarking and data sharing program. And joining us today as my co-host, we can call her, is we have Leah Boone, who's the national coordinator of the CAFC CPDSN program. And it's my pleasure to hand the virtual podium over to Leah to tell us a little bit more about CPDSN and to introduce today's guest speaker. Over to you, Leah.
Thank you, Doug. Welcome, everyone. And certainly today's great attendance speaks to the high level of interest in surgical wait times, and not only the collection and reporting of that important information, but what we do with it afterwards. So as Doug mentioned, for those of you who are not aware, I thought I'd just give a very brief background and share that as of April 1st, 2013, the Canadian Pediatric Surgical Wait Time Project, which was the original project that collected pediatric surgical wait times, has transitioned to CAFC CPDSN in collaboration with our partners, the Canadian Institute of Health Information. This transition has enabled continued collection and reporting of this important data set, data that, as you will see today, in a few moments, can be used to make powerful impact to how we deliver surgical services to Canada's children and youth. Currently, there are 9 of the 16 pediatric academic health centres that participate in pediatric surgical wait time benchmarking. But today I want to share with you also an exciting opportunity. And that opportunity is basically that any hospital in Canada can now start to submit pediatric surgical wait times data through the Discharge Abstract Database or the National Ambulatory Care Reporting System. And after Mary's presentation, we would certainly like to provide a little bit more information, have discussion on that. I'm also going to give a brief plug that this is the first of 2 webinars. The second webinar on July 3rd, yes, and that is around the corner. There will be a webinar that will look and share the national proposal for a PCATS update project, a project that time has come for sure. And we will discuss that a little more further in this program. And I will provide some contact information for those of you online who have not received an invitation and would like to attend. So before we pass the baton over to Mary and I introduce Mary properly, we have 3 brief questions that we would like to poll our audience to help with informing our discussions post-presentation. So over to you, Doug, for those 3 brief questions.
All right, so we're just going to take this opportunity to find a little bit more about what the audience or your familiarity with wait times in general. So what we're just going to ask is three quick questions. So the first one's up on the screen, and we're going to ask, are you currently engaged in any surgical wait time tracking? And some of you may not know. So we do have a don't know option, but it's a yes or no question, or don't know. So just click on the screen and make your selection, and that will actually record it. So we've got most of the responses are coming in here. And we'll share those results. And we can see that 87% of you have said yes. Unfortunately, no one doesn't know. But 87% of you have said yes, that you are currently engaged in some type of surgical wait time tracking. The next question is, have you used pediatric surgical wait times data to affect change in your organization? We're not going to ask you what that change is at this point, but Just asking if, in your, I guess this is more in your opinion, have you been able to use that data to affect any change in your organization? And that's good news. 72% of you have actually used that data, so that's good. 20% of you have said no, and 8% of you don't know if that data has been used for anything. And finally, we're going to ask you, have you ever heard of PCATs? And I'll actually ask Leah to remind us what PCATs stands for.
Okay, the PCATs is a set of standard codes that are Pediatric Canadian Access Target codes that are diagnosis-based. So this is how you assign a code, and then Mary's going to go into more detail as the expert on that. But the acronym certainly doesn't roll off the tongue. So Pediatric Canadian Access Target Codes.
All right. And 77% of us have heard of the PCAT, so that's good. So we've got a reasonably well-informed audience here. So back over to you, Leah.
Thank you. So at this point in time, I'd like to welcome and introduce you to Mary Muir. Mary is the site lead for pediatric surgical wait times at the Stollery Children's Hospital located in Edmonton, Alberta. And Mary is going to share a very exciting success story out of Stollery. And so I'm sure that you'll be thrilled. I'll pass the baton over to you, Mary. Thanks so much for joining us today and agreeing to present your experience.
Thank you very much, Leah and Doug. I appreciate that nice intro. And I'm just going to pull up the PowerPoint. And can everyone see this?
See your screen yet? Have you clicked the Show My Screen button?
I didn't see it. There it is. There. Okay, here we go. How's that looking?
Yeah, that looks much better.
Okay, so I'm just going to start off by, yes, Stollery has actually participated in the initial project from 2007 to the current state, which was the National Pediatric Surgical Wait Time Project, and which ended in 2010 for some sites and continued on for others. So I'll get into a little bit more on that in a bit. But basically, I'm here today to share some of the experiences we've been involved with using this great data and how we've managed to use it to benefit the patients. So thank you for registering today for this, and we can take questions throughout or towards the end. I know Leah and Doug will be collecting any of those if you type a message. So I think we'll start, and basically I think most people have heard of OR Allocation The Old Way, which was an old boys club, and we'll work it out in the golf course. And if that wasn't resolved, then they would fight it out and basically indicate that their patients were sicker, they should have more OR time, or their wait list was longer, they've worked there longer, so they were more entitled to more OR time. Some thought they did more call, therefore they should have more OR time. They had an academic practice, so the teaching took away from their OR time, so they felt they should be entitled to a bit more of that, or it was in their contract, and if that wasn't the case, then they would go to the CEO or Minister of Health if that was the case. And yes, that was kind of the old way of allocating OR time, and we like to think that these days it's not quite the same way. However, having said that, we do have a vision at Stollery, and our vision was basically to develop a transparent and consistent method for managing surgical wait times that was basically data-driven and patient-focused. Having said that, we took the PCAT's data, and the project itself we turned into a program at Stollery. As Leah indicated, it doesn't roll off the tongue, but it is the Pediatric Canadian Access Targets for Surgery we refer to as PCATs. It is a standardized diagnosis-based priority system for scheduling surgeries, and we have these target times in place for all surgical services. These target times were developed by over 100 pediatric surgeons from across Canada for all surgical specialties. The target times are evidence-based when good evidence was available, and consensus-based if evidence was lacking. So we basically use this target time system to measure, monitor, and manage across all surgical services to support comparisons throughout the province of Alberta. So, to the next slide, what is the purpose? So obviously we're here to access surgical services and ensure that our patients are getting this service that they need. We measure wait time too. We call it from the specialist to when they've actually had their surgical procedure. So when we started this project 7 years ago, we didn't have a good measure in place. We thought we were monitoring wait times, and we thought we were managing quite well at the time. However, since implementing this project, we've certainly gained a lot of knowledge with access and how to allocate time. So we're going to get into a bit more on that in a bit. And how we align surgical wait times with the actual capacity we have at our site. So a lot of surgeons will indicate that W1 or wait time 1 is probably a worst case scenario. Patients wait longer. This project aimed at W2 or wait time 2. So the plan basics for Stollery was ready to treat, and there are some different definitions I will refer to. Ready to treat was when the patient is socially, functionally, and medically ready for surgery. So although the decision to treat date may be different than the ready to treat date, we do measure from ready to treat date. So this system has the same uniform presentation, and we apply these access targets to all patients in the province. We are trying to determine the number of patients waiting in target time or past target time, and to develop a comparable provincial waitlist data set. Then we look to investigate and address the root causes for why patients are waiting beyond their target times. So, ready to treat date to surgery complete date is the measure in place here. So how do we use the data to prove access? So I have a few slides that includes data from the project as well as from Stollery. And I just wanted to give some credit to a few people who have worked on these slides with me. Melanie Swab is our analyst here at Stollery, and she works on capacity analysis. So she's created quite a few of these slides, and have shared some of this with Kevin Osiawi, who's created a few as well, and he's our senior analyst with the provincial access team in Alberta Health Services. So they've reviewed the national data, and some of these slides also refer to the Stollery data. So out of the gate, Stollery had to create some waitlist criteria for surgeons and for the site to ensure we were measuring, managing, and reporting elective scheduled surgeries. So we do not measure emergency surgeries at this time, so this is primarily for elective cases. The corporate policy manages what we need to do and enforces what we need to do, and basically that is to review wait lists at regular set intervals, ensure patients aren't on multiple wait lists. If patients have refused 3 dates for non-medical reasons, if their clinical condition has changed, they've received surgery elsewhere, we're unable to contact, there's some waitlist maintenance that happens through this corporate policy. Definitions, we try to have consistent definitions throughout the province, one being decision to treat, which is when the physician and patient agree that surgery is the planned treatment. Doesn't mean the patient is actually ready at that time. So we have another timestamp which we refer to as ready to treat. And that's when the patient is, again, socially, functionally, and medically ready for surgery. These 2 dates may be the same, but they may be different. We find that the ready to treat date is a fluid date, and it can change multiple times. Occasionally patients do not want their surgery until the summer, or there's a multitude of reasons why patients are not ready at their decision to treat date. Another piece of criteria we use is to submit bookings within 5 business days from primarily the decision to treat date and ready to treat date. This prevents some hoarding of bookings We were finding some offices were submitting bookings months after they'd seen the patient. The patients were already beyond their target time. So now we try to enforce the 5 business day rule if possible to avoid that. And then OR scheduling. So our surgeon wait list report is actually formatted for ease of use, and I'm going to get into that in a little bit here as well. So any patients exceeding their target times or patients waiting greater than 1 year are to be reviewed and their access managed appropriately. Do we have any questions, Leah, up to this point?
No, there haven't been any questions yet. So just a reminder to the audience, type those questions in as you think of them, and we'll be taking them throughout the presentation.
Great, thank you. So I'm just going on to the waitlist report, which is now what we refer to as an office tool. Obviously, surgeons and their offices need something to manage their wait lists, and they need access to reports. And we do have access to reports in near real time. So all patients are to appear on these wait lists with a PCAPS code, a ready-to-treat date, and a decision-to-treat date. The ready-to-treat date is updated as needed, and offices do contact us with that information if there's any changes. Patients are also queued using a normalized wait time, and I'm going to show you an example of a waitlist report. And basically how we normalize the wait time is we take the days a patient has waited and divide it by their target time. So it considers their acuity in the wait. This tool is to assist offices with prioritizing the scheduling of surgeries. And I'm going to walk everyone through that. Uh-oh, Doug, what happened there?
I'm not entirely sure.
Should I push?
Let me just make you presenter again and see.
Okay.
It seems as though... Where are you here? Can you see your control panel?
I can.
Is there a round button that looks like a play button on an old cassette deck in the top left?
An old button, top left.
This says show my screen. There should be a row of 4 blue buttons at the top.
Yeah.
Let me just... we'll try this again.
Okay, there's show my screen. All right, I think we're back.
Yeah, we're back. Yeah.
Okay. Sort of, is everyone seeing what I'm seeing? It's a bit cut off.
If you just start to advance if you just click on the slide, it'll, and when you advance, it'll be fine.
There we go. All right, so we're going to move on to the sample of the waitlist report. And I'll walk everyone through this. So I just wanted to indicate that the surgeon's clinical opinion will always override what the target time is saying. So we are just going to use this as a sample. Obviously, this is a portion of a waitlist report. An actual surgeon's report would have the patient's name and number and the physician. So on the top left-hand corner, there's an area for the PCAT code. So this is what the surgeon's selecting for that particular patient, with the attached diagnosis description for that PCAT code. So the third column is the DTT date, which is the decision to treat date, the RTT date, ready to treat date, which may be the same, or it could be a different date. And then demand date is the date in which the patient will surpass or their target time. So this is the date that, or the tool that becomes valuable for the office. So when they're scheduling their OR time, they're looking at that date to ensure patients are being scheduled prior to them moving past target time. So the OR dates, so you can see the dates of the OR for this particular surgeon. Target days is the target time attached to the PCAT code. So this first one is a 42-day target time for reflux without esophageal stricture. And when I ran the report yesterday, this patient had been waiting for 63 days, and that's from the decision to treat date. Now, they have surpassed their target time by 21 days. So from 42 days, the 63 is now 21 days past their target time. This section here, the target percentage, is what we call the normalized wait time, and that's where the patient's days waited divided by the target days gives you a normalized wait time. So if this patient had been waiting 42 days, they would be sitting at 100%. So they've passed 100%. So you'll see down the row some patients are in a negative number, and that basically means they have not yet reached their ready to treat date. So these last few patients, last three, have an August 1st, August 15th date for when they are actually ready for surgery. So we don't count them, but they do show up on this report so surgeons don't lose track of the patients. And we don't actually consider them ready and waiting on our other reports until those dates kick in. So they'll show up as a negative number. Any questions on that at all?
Question come in from Darlene, and she's asking, how do you actually reinforce the 5 business day of OR booking rule?
Okay, that's a great question. We actually, it's a number that we use. We try to get offices to submit their bookings in a timely manner. This was used primarily for the offices that were hanging on to bookings for months. So I would say we may have 2 offices out of 60 that we really need to deal with, but it's part of the criteria they need to meet for OR allocation. So as soon as you indicate it's about OR time and how you're going to gain access to OR time, you will not be considered unless you're following the criteria. So some offices, they do a good job and they're submitting their bookings within 5 days or less. Others are maybe 10 to 12 days. It's not a hard and fast number. We don't stick to it, but we expect within reason.
Thank you. That's the only question we've got on the list for now. But keep your and someone else, Sebastian, has actually just asked, okay. How do you deal with patients' unavailability, summer trips, etc.?
Right. So we call our system an enhanced system. An enhanced system does not remove unavailable times. We primarily start the clock ticking from when they are ready. So that's why we indicated that the ready-to-treat date can be a fluid date. I know an optimized system will remove unavailable times. And because we're doing this consistently across the province, yes, it's not the perfect system. We're moving towards an optimized system, but for now, that's how we're dealing with all of our unavailable times. So unfortunately, the clock starts ticking when they're back to being ready. Okay?
All right, and that's it now. And if anyone asks a question and has a follow-up or we haven't answered your question fully, please don't hesitate to put in a follow-up comment or question, and we'll try and get that into the conversation as we go. All right, so back over to you, Mary.
Thank you, Doug. So we're going to get into the analysis part of the data now and what Melanie's hard work has done over the last few years and how we use it. So we actually look at OR resources. We also look at other resources. So OR resources, we're looking at utilization rates. We're looking at their demand for surgery, if they have enough capacity to meet the demand. We're looking at other resources such as anesthesia, bed availability, different indicators such as those. We also look at waitlist management and if offices are managing their waitlists and their scheduling practices. Are they using the tool for scheduling, taking off of the top of the list versus random scheduling, picking any patient off the middle or bottom in the black versus the red. So the next example shows where Dr. X has a significant percentage of patients waiting beyond target time or too long for surgery, so in the red or purple area. And then how the demand versus capacity chart shows that actually Dr. X has sufficient OR time or capacity to meet the demand for surgery. So we actually, one of the indicators is demand for surgery and enough capacity. So if the surgeon has enough capacity, why isn't he meeting the demand? Why aren't his patients out of window? So when we started looking into some of the information and we would meet with surgeons, there are different variables involved. And for this particular surgeon, when we sat down and met, we said, well, you have an awful lot of patients in the red that you're completing versus a lot of patients in the green, which we refer to as being too early in window, and then the yellow being just in time, and the red being beyond service. When we actually sat down with a surgeon, he indicated that he didn't have enough beds. He had enough OR time, but he was only able to book 3 same-day admit patients in a day. So primarily the number of patients in the red were ones waiting for beds. So now we're able to look at some resource allocation and take our resources and put them into possibly a 24-hour unit. So this surgeon in particular didn't need a bed per se, but needed an overnight stay or an observation. So this is where the data starts. You can start to use the data to work for more resources for certain issues. This is just one example, and we basically were able to identify quite a few issues that we needed to address. So the biggest one obviously was the waitlist management or scheduling practices. The number of available PEDS ICU and CV ICU beds were an issue for us. The number of available ward beds was contributing to our out-of-window numbers. The number of anesthetists at our site, we had a few vacancies, and they contributed to quite a few of our blocks being closed or OR time being closed. And then variable utilization of our ORs. So surgeons weren't using their full utilization. We measure based on 80%. So we realize surgeons have holidays, they have professional conflicts, they're not able to utilize 100%, so we mark at 80%. We also do not have an emergency OR, so when we have emergencies coming through, they often bump our elective schedules. And the insufficient number of ORs for our large workload contributed to some of our out-of-window numbers as well. So we were able to identify some of these issues to start making some arguments for more OR resources. Now we're just going on to a few slides comparing the national data with the Stollery data. So this next chart.
Mary, before you go on, another question just came in.
Okay, sure.
Lenny has asked, how do you make sure the PCATS codes are being used correctly? Who decides PCATS, surgeon or MOA? I'm not sure what MOA means, but...
Medical office assistant,
oh,
yes.
there you go. Yeah.
You know, it's sort of random. Obviously, best case scenario is the surgeon selecting the PCAT code, but the reality is quite often it is the medical office assistant doing it. Whenever possible, we try to get the surgeon to do it. I guess this is primarily it's affected when it affects their OR time. So if the medical office assistant is picking the code and the surgeon's not watching it or is feeling is being hit by OR allocation based on the code, that's when they start to become very engaged. Some of these codes can be selected by the MOA. I don't see that that's a huge problem, but best case scenario is if the surgeon is selecting that code. Does that answer the question?
Looks like I'm sure it did. So we can.
Okay. All right. So this next slide is the national data. So when we were involved with the project, from 2007 to 2012, you see how many cases were completed and how many patients were waiting. And you'll notice there's a significant drop in March 2010, and this is when the funding stopped from Health Canada with the project. So a few sites dropped out. So we were at one point up to 24 sites across Canada submitting data, and when the funding stopped, that dropped off. But this diagram basically shows the number of patients waiting and the completed numbers stayed parallel, which you would expect to see more or less. When we reviewed or drilled into the national data a little further, and we started looking at the waiting out of window and completed out of window, one of the things we noticed, the top bar, waiting out of percentage, it tended to grow slightly, whereas the patients being completed out of window started to drop. And there are a couple of reasons for this. And I'm going to show you the next slide. And these are basically the different alternatives that sites could use. And that was to measure and monitor only. So don't do anything, just measure it and monitor. Second scenario is to manage just the completed cases. So ensure you're completing your cases in window. So when we reviewed or drilled into the national data, a lot of sites were doing this. They were focusing on the completed cases. One thing Stollery did, which was scenario number 3, is we focused on the cases waiting. So we felt that if the cases waiting were in window significantly, they'd take care of the completed cases. And our numbers looked worse for a while because we were focusing on all of the out-of-window cases and trying to get the backlog down. So our out-of-window numbers did not look great for completed cases. However, they started to improve gradually, and slide 28 will show you that. I'll get to that one in a little bit here. So one of the reports we primarily use for our senior management is a report that shows service and surgeon. The total number of patients waiting, and then the patients waiting out of window, and then the percentage waiting out of window. So we look at this one report for the service, and then we drill down into the surgeon to see if one surgeon's driving that number up or down, or primarily up. And we try to deal with that as probably bi-weekly more than anything. So one of the measures we have in place for the capacity analysis piece is the surgery demand window. So our service is scheduling according to this demand window. When we started looking at their capacity, it showed that they actually had enough capacity. It just came down to some randomized scheduling for their surgeries. So what we liked about this system is that it considers all patients in the queue. We were doing a really good job on our urgent emergent cases, not so great on what we refer to as L3s, or the patients who could wait greater than 6 weeks. So this system actually considers all patients in the queue, and it considers the acuity when prioritizing them with that normalized wait time. So I'm going on to what that actually looks like. So these are just key dates and concepts in the wait times management. So we look at them in 2 parts. So even though we're measuring W2, we break it down to 2A and 2B. So obviously 2A being the surgery decision date. And if all of these indicators below the 2A, the tests and consults, adjuvant therapies, stage 30 surgeries, repeat surgeries, patient availability date are all good to go, then we start measuring from decision to treat date. If any of these are changing, patients are unavailable, stage surgeries, they're needing an MRI or any other, maybe a sleep study, then they are not actually ready, and we start to count at 2B, and this is the measure here. The next slide shows you too early in window, ideal, or we call this scheduling just in time, or past target time, and it's too late. So this is what we're aiming for. We want patients scheduled too early, if possible. We want them scheduled just in time. And we don't want them scheduled beyond target time whenever possible. So these are just the dates and concepts that we use. Are there any questions to this point?
There's no questions right at this point. So.
Okay. So I'm going to show you an example of what a normalized wait list would look like, and you'll see the colors along this list of patients. And you can see how the target times are very random in this selection, but this is how the computer will queue the patient. So even though this patient, Michael, has a fairly acute target time, he's actually not the one at the top of the list. The patient, 365 days, is ahead of the patient with the more acute time. So we're saying the green, which is Kevin, and then the next grouping in the yellow, which is Jennifer and Debbie, and then the next three in the red are already beyond their target times. So this would be the order a surgeon would select for their OR times. Obviously, these patients with the more acute target time will rise to the top of the list much quicker than maybe the patients with a lesser acute target time. So this is part of what we're looking at, the green, yellow, red queuing with the considering the acuity in that concept. So part of our analysis is ensuring that all services have enough OR time to meet the demand for surgery. Some services we found have a deficit and some have a surplus. So with the red bar being alignment, we had some services that were above or had a surplus of time, and then a few services that were below the bar that were not being aligned. So in November 2011, we adjusted some of the time, and we met with our surgeons and our services to say they had a surplus of time, and it's important to know that this is unused time. So they weren't using it, they were forfeiting this time. So we wanted to reallocate the unused time to the services of need. So service A, B, C, and D. So we don't want to take from Peter and give to Paul and then have an opposite effect. So we watch this very closely to ensure these services stay aligned, and we're trying to bring the services with a deficit up to the bar. Now, after about a 6 to 7 month review, we noticed that we did overshoot a little bit for service A. We certainly made some improvements with service B, a bit in service C and service D. Now, this information is being reviewed every 4 months, and we only make changes if we really need to, and we try to have all services aligned. So, for instance, because we overshot in service A, they don't own the OR time. The OR management team owns the time, and they reallocate it according to need. So we try to ensure everyone has enough OR time to meet their demand for surgery. Are there any questions on this slide and how we do this?
No, there's no questions on this one. But,
okay. This was probably the biggest significant improvement we had during the project in the sense that we were moving along with our completed cases and our out-of-window waiting cases. They dropped off a little bit along the bar here. However, we didn't see significant improvements until we did do the reallocation of time, and you can see how our waiting out-of-window volumes dropped drastically. And that is now being constantly reviewed and watched so that people have enough time for surgical access. So this next graph, after we reviewed the out-of-window, waiting, and completed, what it showed us is that, yes, our percentage completed out-of-window grew a little bit, but it started to drop off. And our waiting out-of-window numbers dropped significantly. So much so that we were actually sitting at about 87% of children within their target times, whereas prior to this we were sitting at about 30 to 35%. So that was a huge jump for us. And this next chart just shows that we do a few more surgeries than we used to, and probably because we were utilizing our OR time better, and the percentage of children waiting out of windows obviously dropping too. So there was a significant decrease in the number of children waiting and an increase in the children being completed when we started this work. So when we benchmarked across the country, we picked 7 hospitals, and we were pretty well on par with the hospitals. So out of the 7 hospitals, an average wait, the children were waiting about 108 days in 2009. At Stollery, it was 101. So we were pretty even with that group of 7. By July 2012, after we had implemented a lot of our changes, the national benchmark was sitting at 174, and Stollery decreased by quite a bit, and their average was about 53 days. So the national sites, or the benchmark hospital sites, increased by 61%, and Stollery managed to decrease their numbers by 47%, just using the data. Now what this looks like are, as I indicated, sometimes your out of window numbers, they get worse before they get better. And this graph shows that we were at about 74% of surgeries completed in window. It dropped down to about 73%, and then it started to gradually improve to 77%. And the patients waiting out of windows, there was significant improvement. So when we started out in June 2010, 30% of our patients were waiting beyond their target time, and it gradually dropped down. And in June 2012, and this is a little bit old now, but we were down to 13%. Our goal is 10% or less of patients waiting out of target time, given some of the variables we're dealing with, such as postponements, patients or no-shows, patients get bumped by emergencies. There's quite a few different variables why patients move past target time. And again, because we focused on the front end, or the wait time, patients waiting in window, out of window, the back end started to take care of itself. Any questions?
Sonny has asked, if you go back to slide 24,
okay.
He asked, how come the number of cases completed, goes up by a lot, but the out of window goes down?
So we started focusing on the out of window, and we were utilizing our OR time fully. So there was still a lot of, it's difficult to fill forfeited OR time. So a lot of OR time was going unfilled because we just couldn't find services to fill the time last minute. So since the reallocation of the OR time, services were now able to plan better and fill that time. And that's primarily why the numbers, the out-of-window volumes dropped. And we still were doing, I guess, different types of surgery. So we may have been doing maybe more spines versus more ear tubes. So we're measuring volumes here. So yes, it's a little bit less, but not by a lot.
Okay.
We just kind of went along. Does that answer the question?
I think so. He's sort of looking more closely at the legend now, and I think we've answered it. Sonny, just let us know if we've answered your question. I think he might have been looking more around why there wasn't more of a linear relationship between completed surgeries and out of window, like sort of an inverse, more linear relationship. As one goes up, the other one would go down. As you're completing them, the number of out of window would go down at the same rate. But
right. So we're actually using existing resources, so we're not getting more OR time, but it's just how we're managing and scheduling our surgeries. All right.
All right.
So.
Leah's got a question for you.
Okay.
Mary, with regards to the reallocation of OR time, I wonder if you can make some comments and share about the sort of the change management experience, speaking to the culture that was at Stollery before this and how that shifted and what some of your maybe lessons learned were?
Sure. I'd love to do that. So yes, OR reallocation, I mean, we found at the end of the day some services did have a surplus. It's difficult to fill the forfeited time. So with better planning, why would a service have more OR time than they need if they're not using it? So when we actually did the reallocation, it did take quite a long time for us to reallocate the time because we're dealing with different clinic times, different office dates, different services. You can't just assign a Monday to a surgeon and expect them to be able to work that Monday. There was a lot of work that went involved in reallocating the time, and a long wait list isn't necessarily a need for more OR time. It's how they're managing that list. So when we were meeting with our surgeons, we were asking them what their issues were, and some of them it was beds. Some of them it was a variable across the board. So we looked at different initiatives and how we could strategize to get some of these surgeries completed and clean up the backlog. So once we were able to clean up the backlog, and if they still had a deficit, then we had to do something and reallocate some resources to those groups. Definitely, that was not easy. Surgeons would argue it, but the data is what really pushed it through. And when they're looking at their capacity analysis report, and it's showing that they're utilizing 50% of their OR time and not the 80% that's expected, you could probably hear a pin drop in the room. They know it. You don't have to tell them. They do know it. So the biggest thing is that we do provide reports to them on their utilization rates. We do it for the service, but we can also drill down to the surgeons. If one surgeon's driving that, if there's different reasons why they may be utilizing less time as well, maybe other issues that we haven't considered. Maybe they have professional conflict days, such as their day of the OR is a teaching day, so they can only work till noon on their OR day. So we actually try to understand what their issues are and why they may not use or utilize their OR time. Once we allocated the OR time the first round, surgeons tended to pay more attention to the codes they were using. As the earlier question came up, who's applying the code, the surgeons did start to apply the code more so themselves than their secretaries or their medical office assistants. So that was a win-win for us, and you only will get the OR time you need to meet the demand for your surgery. You can't use any more. We did have some different initiatives going on at Stollery. We would find some resources, existing resources in the summer months when we went down to closures, and we would address the out of window. And I hate to use the term out of window because it sort of sounds like we're rewarding bad behavior, but if they're utilizing their time, if they're scheduling accordingly, they're submitting their bookings in time, and all of those pieces are being done and they're still running a deficit, then they are going to need more capacity. And that's our job, is to ensure they have access to surgical services for these patients. So that's a little bit on how we reallocated the time and what was involved in that piece. Any more on that?
Yeah, another question came in.
Okay.
Leslie's asking, do all of your services pool their resources, and or is surgical time allotted to a specific surgeon? So, for example, how do you manage when one surgeon has a short wait list and another's is much longer?
Okay, that's a great question. So what we've tried to do is have services work it out themselves. This works well for some groups, not so well for others. Management steps in when they have to, but at the end of the day, we try to get the services to work together. They allocate their time. We don't look at it as a surgeon-by-surgeon basis. Primarily, it's more of a service. Occasionally, we do have to look at surgeon-by-surgeon because some surgeons do drive the wait list. But when we meet with them, we have the discussions on the patients on their list, if their colleagues can help them out, if they need to redistribute their list to their colleagues. Are they utilizing the time they have? Can their colleagues provide their same-day admit beds? If it's the bed issue, we've looked at all sorts of different issues, and we do try to get them to work it out within the service. Now, we do have a surgical lead per se in each service, and I would say that works well probably 80% of the time. Occasionally, we do have to step in and try to assist with working some reallocation out. because this is a constant measure and we're rejigging it to meet the demand, as soon as a service is aligned, we want to keep them aligned, and we try to address the services that are running in a deficit. And we try to project which services those are. And I'll be frank when I say it really does come down to scheduling practices most of the time. Having said that, the ones that do have a deficit, at least we know who to offer the forfeited time to when forfeited time does come up. But with the reallocation of the OR time, that also changed significantly because we actually had less forfeited time. We had more or improved utilization rates. So now it's a matter of capacity issues. We don't actually have enough space to meet the demand. We are going into a redevelopment right now, so we will be building more ORs. But for the time being, we're just trying to rejig things to best fit the situation we're currently under. So I'm going to move on to local solutions because I think that ties into what we're getting at a little bit. So when we talk about waitlist management and basically optimizing that piece, so again, goes back to scheduling, ensuring offices are reviewing their waitlist, that patients aren't on multiple waitlists, that patients haven't been double booked or have had their surgery elsewhere. So there's a monthly review, and offices are asked to review their list. And sure, they primarily look at the patients in the red that have surpassed their target time. And there needs to be some action on those. One of the indicators that we measure are anesthesia staffing because they contributed to a lot of lost OR time. And we try to optimize pediatric anesthesia in our OR. Now, my understanding is there is a shortage across the country, so this is a bit of a moving target, unfortunately. But at the best case scenario, if we had our full complement of anesthesia, we'd be in a much better situation even today. One of the other solutions we looked at, there were some staffing issues in PEDS ICU, so we had a difficult time accessing PEDS ICU, and our surgeries were being canceled because of it. So we were able to take the data and ensure that additional resources were in place to address those concerns, as well as a new cardiovascular ICU is in process to meet that demand. Obviously, our OR utilization has been improving, and a lot of that is contributed to these OR template changes, and as well improved understanding of how we're using the data. That's been a big win for us. We do increase some time in the summer months. A lot of patients, especially pediatric patients, would prefer their surgeries in the summer months. So we look at opening up capacity analysis rooms for those to meet some deficits. Also, increasing the number of ORs will assist with this redevelopment piece, and we will include an emergency OR so that we're not being bumped. Our elective cases are not being bumped by emergencies. And hospital beds, surgeons are now discharging patients earlier in the morning, so beds are available later in the day. And we are working on acquiring some resources for a 24-hour short stay unit. A lot of our patients are using overnight beds that they really don't need. So a short stay unit would really improve a lot of those issues that we're having right now. Any questions around this piece?
One question did come in from Sharon. She's simply asking, what is your management structure? And Sharon, feel free to put in a comment if Mary's answer is not quite getting at what you're asking. But she's just simply asking, what is your management structure?
So I'm assuming it's regarding OR allocation, and we primarily have our pediatric surgeon, chief of surgery, is part of our team who reviews the data and makes recommendations, along with myself with the wait time program, my colleague Melanie, who's with the capacity analysis and collects and measures the data, and along with our unit manager for the OR, day surgery, as well as the patient care manager for the operative services area for pediatrics. So we're the primary people that look at the data, meet with the surgeons, meet with the stakeholders to make recommendations and decisions based on this piece. Sharon, have anything in addition to that question?
She hasn't commented, so we're going to assume that we've answered her question.
All right, sounds good. Okay, so basically management of surgical. So we've talked about the measure, we've talked about monitoring, and we've talked a bit about the management of the surgical waiting list. And basically these waiting lists are the backbone for all of our measures, and well-maintained waiting lists are the primary focus. We need to ensure that all of our patients are registered. They all have current ready-to-treat dates, and getting back to the appropriate PCAT code that is used, there is a validation or a chart review that's randomly done a couple times a year. And when we are validating the completed cases every month, we are looking at the codes being used, if they're being used appropriately. Some of our surgeons will also weigh in on the validation piece. So our surgical lead is reviewing a lot of the wait lists for their services to ensure, A, are their patients being done within the target time? If not, why not? And why are they coding a certain way if there's a question around that? So it's a real team approach, and we try to engage all of our users at the end of the day. This queue-based scheduling system is basically patient-focused. So are we doing the right patient at the right time? And to have optimal processes in place reduces our resource limitations. We can easily identify, confirm, and quantify, and if we need to make any changes, we have the data there to support the decision making. So the value of good data, we can never say that that isn't worth something. And if we're measuring in a consistent way, and we're measuring everyone the same way, you have quite a robust system, and it actually improves effective management of surgical waiting lists. The surgeons did develop these target times. These are patient-focused, so you can't get anything better really than that. And this comprehensive and comparable data, we're now comparing apples to apples. What we're seeing here at Stollery, we can take down to Alberta Children's in Calgary, look at their data, and we now have a good comparison to say, why are you guys doing such a great job in dental, and maybe we're not? What can we do that you're doing? So there's a real ability to identify some of the resource limitations and understand what the efficiencies are. So this only enables surgeons, hospital and administrators, even the province to make some decisions and optimize the timely access to surgical services, because that's what it's about at the end of the day. This was a great project to work on. We did a lot of networking across the country, got to meet some great people, and understand that our questions were very similar to other questions across the country. Our issues were other people's issues. And it just became a sense of understanding more than anything that if we got a good measure in place, how to monitor it, and then what can we do to actually manage it. So I'm wondering now if there are any questions to this point.
All right, so that's the end of the presentation, is it, Mary?
This is pretty well, yep.
All right,
if there's any question, I'd be happy to take.
All right, so so if you do have any questions, please do type them in. We do have one from Randy who's asked, you've sort of made some comments about when you're scheduling a surgeon, you don't expect them that they will be available on a particular day. He says, do you have a target or an expectation of their availability, though? He said, for example, some provide their availability 1 month in advance, others provide 3 months availability in a schedule. Do you have any targets or expectations in that regard?
So again, getting back to, we look at the services overall, not the surgeons primarily, so we let the groups work that out themselves. So if Dr. X is going to be away in July and Dr. Y will be around, then they will swap out their time or allocate their time according to that. We do have some services that work together in the sense that they share their patients. So some of our dental offices, there may be 5 dentists in one office, and they'll share their workload amongst themselves. So they're basically doing the next patient in at the top of the list. That works for some groups, not all. We try to project when surgeons are away. So when we go into closures for summer, for instance, we're not going to schedule a surgeon who's away, for instance. Their colleague may take that time, and they may take their colleague's time. So it's kind of a combined effort, surgeon service and or availability.
All right, and that is the only question we have now. So, and we've taken quite a few questions throughout, so I'm sure we're probably running out of questions, and we are past 12 o'clock, so we're probably starting to lose some folks anyway. So maybe we'll wrap it up there, and we'll leave it to you and Leah for any final closing comments.
For sure, and I have provided my contact information on the last slide. If anybody has a question they think of later, I'd be happy to answer anything as well. And Leah, you were going to provide your contact information too, weren't you?
Yes, as a matter of fact, Samantha DiLeonardo has just sent in the chat box. You will see the name, date, and time for the next CPDSN webinar, which will be about the National Proposed PCATS Update Project. So today we talked about the importance of the PCATS and how they affect the data. So really, the purpose of the July 3rd webinar would really to engage all those who are online today. So if you've not received an invitation, my email is in the chat box. Please send me your expression of interest, and I'll ensure that you will get the invitation. I'm delighted to share that Mary Muir, Sean Hillhouse, who's the manager of the OR area at the Stollery, as well as the 2 surgeons-in-chiefs, both for the Stollery and for Alberta Children's, have come together to offer a commitment of some leadership resources for a PCATS update project. As we know, with all good standards, there comes a point in time where you need to update the codes so they reflect the real world, and that your data not only gets enhanced, but it has to be current to be valid. So we are delighted and would love to accept that offer. CAFC CPDSN has made the commitment to coordinate that project, and we are looking for our colleagues across the country to participate in the webinar, where we'll discuss in more detail what is being proposed, process, timelines, and what we are looking for in terms of lending your expertise and your lens from your jurisdiction to helping this happen. So with any standard that is national, it's important. Mary talked about the apples to apples comparison. Well, it is very important that if we're moving forward, we move forward in step on a national basis so that we come to consensus on what the updates are, and then our colleagues at CHI will make it happen. That's sort of in a nutshell. So I really am looking forward to hearing from those who would like to attend and add you to our list. And really, I think, Mary, you made the compelling case very clearly. It's not just about collecting the data, it's about engaging and relationships between services, between all providers, between all those who have the data, and really sharing and using the data collectively to work out the differences. So I hope folks have gotten a few gold nuggets today. I know I have. And Mary, I'll turn it over to you, and if you have any closing comments.
Okay, thank you very much, Leah. I really appreciate this opportunity today. And I know how valuable this project's been for us here at Stollery, so much so that the province is using the PCATS model to roll out an adult initiative with the same type of format for our adult world. So that work started about a year and a half ago, and it's exciting times here in Alberta. Using these types of priority systems really makes a lot of sense, and we've gained a lot of traction with it. So it's been great. If anyone wishes to contact me or send an email, by all means do so.
Mary, it's Elaine. I just want to thank you for your leadership, first of all, in presenting today, but certainly on site and within your province. I agree, to have I'm going to refer to it as a pediatric model be applied across the adult system says a tremendous amount. And I really just wanted to extend our congratulations to you and your team. We're certainly proud to be supporting this project. We're proud of our partnership with CIHI in continuing to track these key data. And of course, as Leah said, we're going to learn a lot more about that on the next webinar on July 3. But just thank you for today and for the tremendous work you're doing.
Oh, thank you very much, Elaine. It's really been a lot of fun.
Thank you, Mary, for such a great presentation. It really was fantastic, as you can tell by all the questions and the discussion that this generated. So we're certainly, I'm sure people will be contacting Leah to sign up for the one that's next week. And we did have one final question from Tanya, who's asking if there's a recorded version of this webinar. And in fact, there is. As I mentioned at the beginning, we do record all of these and we post them on the CAFC Knowledge Exchange Network at www.ken.cafc.org. It does take a couple of days for those to come up, and anyone who's registered for this or signed into this webinar, you will remember that you signed in with an email address, so that there will be a message that gets sent to that email address with the direct link. So you should expect to see that in the next couple of days. And so with that, we'll close this one off. We do these webinars as part of the CAFC Presents webinar series every Wednesday at 11 a.m. Eastern Time. It will be a little bit spotty over the summer. We won't be doing them every Wednesday over the summer. And as Leah mentioned, she has one on July 3rd, which is not a Wednesday and not part of the typical CAFC Presents series anyways. But so just go to the cafc.org website. If you do need any more information about our webinar program, there's a section there called CAFC Presents, and there's a calendar, etc., where you can always find out more information about the upcoming webinars. So we do thank you again for coming and hope to see you on our next one. Bye, everyone.